I thank Dr. Madhusudan, Dr. Govind Verma, and Dr. Fani for inviting me. I thank Dr. Umadevi and Srikanth for making my talk easier because they covered most of the things. So let me focus briefly on the bile leaks. So post-op biliary complications, as my previous speakers alluded, comprises of bile leaks, bile duct strictures, and cholangitis. Bile leaks are more common in the first 1 to 3 months, and overall incidence ranges from 2 to 25%. In high volume centers where there are expert transplant surgeons, the incidence is really between the 2 to 5%, but newly set up units and some different technical practices leads to higher biliary complications, as well as the age group of the pediatric population also results in higher complications in the younger group. Leaks are more common in LDLT, obviously, than DDLTs, and these can be delayed in few patients. So I selected this 16-year follow-up data from a center where there is a 67 pediatric patients had LDLT between 2003 and 18. Male-female ratio was 10 and 27. In this group, they noted that biliary complications risk was 10.5%. And if you look at the biliary leak and biliomas with biliary leak combined, they accounted for 7%. And then cholangitis also can be accompanying with the strictures as well as the leaks. So on the long-term follow-up also in a center where there can be an increased expertise, the incidence remains stable. And when we come to the risk factors, LDLT being a split transplant and hepatectomy with cut surface bile duct leads to more bile leaks. Split liver grafts obviously have more leaks than complete liver grafts. T-tube placement and accidental fallout or early removal of T-tube is noted to be associated with increased bile duct leaks. Enteral anastomosis, that is choledochogestomy or hepaticogestomy, is associated with more bile leaks than duct-to-duct anastomosis. Re-exploration for any reason in the first 1 week of the transplant also is associated with increased bile duct leaks. As you all know, hepatic artery thrombosis, early or late, both leads to bile duct ischemia at various levels, and that can also contribute to bile leaks. And multiple biliary anastomosis, if there are more biliary radicals to deal with during the surgery, that can lead to bile duct leaks. Circulatory arrest in a donor and the prolonged ischemic time and prolonged surgery leads to intrahepatic ductal strictures and bile duct ischemias, which are in turn leads to intrahepatic biliomas. Where do they leak from? They usually leak from anastomotic site. Sometimes cystic duct stump leaks can be there, and most often in the pediatric age group, cut surface leaks are very common. Intrahepatic leaks are, as I just mentioned, are due to ischemic bile ducts and then hatch. Unlike bile duct strictures, where there should be increased clinical suspicion, bile leaks of significant size will be self-evident with the patient becoming sick with abdominal pain, fever, and abnormal LFTs when they develop a bit of cholangitis or occult infection. What investigations we need to focus on in this group? Usually there are not many. So ultrasound abdomen just to confirm, and MRCP is good enough to localize as well as give a overall view of bile duct morphology and site of leaks. Wherever there is a HIDA scan available, this can give the similar amount of information. I don't think HIDA will add anything more to MRCP. Most of the time, it is self-evident that bile is leaking from the drains or when we place the drains, but in the immediate post-operative period, if there is a doubt whether it is a serosanguinous and bile mixed fluid, the bile fluid bilirubin should be more than 3 times the serum level. Drain fluid culture and sensitivity has to be done, although many think that there will be contamination, but in some immediate post-transplant period, the drains can be left for longer periods, so a meticulous antibiotic therapy is useful in reducing the morbidity and prolonged hospital stay. Complications, early bile duct leaks leads to secondary infections and sepsis, and significant bile duct leaks will result in graft dysfunction, and as I just mentioned, prolonged hospital stay can be seen in early bile duct leaks. Late bile duct, late complications include biliary stricture formation, particularly non-anastomotics. One of the pathogenesis is the bile is a strong irritant, and if there is a periductal bile collection, that can cause changes in the biliary anatomy, and that can lead to non-anastomotic strictures. Multiple biliomas can develop because of the ischemia. Graft can be lost because of these intrahepatic complications, and there is reduced graft and patient survival on the long-term follow-up. Management, ultrasound-guided percutaneous drain is sufficient in minor leaks, and ERCP need not be done, as Dr. Srikanth just alluded. ERCP should be done by expert ERCP person and in a controlled setting with a good technical support using appropriate pediatric compatible instruments, but most of the time we will end up using adult scopes. ERCP with only biliary sphincterotomy can be tried for cystic duct stump if there is a risk of infection and patient is unstable without stenting, but anastomotic leaks and upper ductal leaks should be stented. If all these fails in about 20 to 25% of patients, surgery for reconstruction biliary surgery is the alternative. As you can see in this picture, multiple intrahepatic bile strictures which are complicated by biliomas can be seen because of the wider ischemia and multiple factors. Whereas non-anastomotic stricture, as you can see in the right lower diagram, is due to these biliary leaks and also segmental ischemia. Outcomes, most minor leaks settle with percutaneous drain with antibiotic cover. ERCP and only sphincterotomy will help in minor leaks, cystic duct stump leaks like. ERCP with stent will reduce the leak in majority of the patients. There is a, if you trawl the literature, 76 to 88% will resolve with this approach. Leaks usually close in 2 to 5 weeks, except in cut surface leaks. Cut surface leaks will take 5 to 6 weeks, so one should not remove the stent for 8 weeks in cut surface leaks. Stent removal, otherwise in other cases, can be done in 4 to 6 weeks' time. Biliary reconstruction surgery is needed in some if there is a persistent leak with non-responding stricture. Cut surface leaks, I take an example from last month, one 14-year-old boy who looked nearly 10-year-old with a 4 weeks post-LDLT for Wilson's disease, came with abdominal pain, fever and distension. UHG showed peripheral collection. MRCP showed slight prominent intrahepatic duct with collection. Percutaneous was draining 600 to 800 ml. It was not coming down. And here you can see on the ERCP that there is a prominent intrahepatic duct, but otherwise no. There is a percutaneous drain you can see, and then the rest of the duct is fine. On repeated dye injection also, there is no demonstrable significant leak, although it is leaking 600 ml. So we placed we did a sphincterotomy and placed a stent, 5 French stent across, and drain output reduced to 150 ml in 3 days. So percutaneous drain was removed after 10 days, and stent removal will be done in next few weeks. Here we avoid doing dilatation at this stage, although there may be early stricture. Because of that, there could be that will increase the cut surface leaks. Long-term outcomes, if you look at the long-term follow-up data, there is graft and reduced graft and patient survival on long-term follow-up, particularly if there is a early significant bile leaks. Thank you.